Okay. I think we are good to start. I hear the traffic is very bad, but let's start. And let me start by saying, dear friends and colleagues, honorable guests, thank you so much for coming and welcome to the launch of AI4HealthyCities Health Equity Network, a global Novartis Foundation initiative that we start here with you today in New York City, with the fabulous partners of the City of New York, NYU Global School of Public Health, with Microsoft AI for Health, Health and Hospitals. Mitch is also with us. Thank you, Mitch. And all together, we are launching AI for Healthy Cities because we want to challenge the current realities that where you live today determines your health. And we want to challenge the current reality here in New York that in neighboring zip codes, you have a difference of life expectancies of 10 years. Or in neighboring zip codes, you may have a 25% higher risk of cardiovascular acute event like a heart attack. This cannot continue. So AI for Healthy Cities aims to bring together data and understand what really drives our health. We know that only part of our health is really following the access to quality health care we have or we don't have, but the vast majority of our health is influenced by the conditions in which we are born, grow up, live, and age. In fact, COVID even put a spotlight on that and on this interface between society and health. And COVID also gave a face to inequity that we can no longer ignore. AI for Healthy Cities will combine data from the health system, and here in New York City, we start with the data from health and hospitals, with data from other sources, health influencing sectors, to really understand, with the use of innovative advanced analytics, to understand and progress how we see what kind of social, economic, or environmental determinants are really driving the health outcomes in the population of New York. The data-driven insights we hope to deliver will not only serve research purposes, but will have to be really translated into action. We hope to offer decision makers with tools that they can make better choices of which interventions will have the largest impact on the health of the greatest number of people, or that they can better decide to which partner organizations they have to reach out to work together and address these different elements in the social domains of our life. AI for Healthy Cities will focus on cardiovascular health. And why is that? Simply because cardiovascular disease is the leading cause of death and disability in the world, with 1 out of 3 deaths caused by cardiovascular disease, and often in people under the age of 65. So, and on top of that, we know that there's a projected increase in cardiovascular burden in the US, specifically in the coming decennia. And we estimate that there's going to be 30 to 40% more cardiovascular risk factors in the population of the US, meaning people with high blood pressure, diabetes, or high cholesterol, and as many 30–40% of people more experiencing acute cardiovascular events. The worst thing is that this projected increase in cardiovascular burden is disproportionately affecting the racial and ethnic minorities, exactly the same minority population groups that have been hit hardest by COVID. And in fact, the COVID influence on cardiovascular disease, we only start to understand a little bit of it. We know, for example, only recently that for people who experienced COVID or were hospitalized with COVID or even ended up in the intensive care for COVID have a respectively 2 to 4 to 6 times higher risk of experiencing a heart attack and a stroke. So we don't know yet what the effect of COVID will be on these alarming projections even for the next decennia. And this is why it's even more important that we help policymakers to target their interventions to those populations who need it most. And they have to target interventions in the health system to make sure that people who have cardiovascular risk get detected earlier so that we can control them, and that they get a very good access to quality care in an equitable way. But on the other hand, the decision makers also have to target to which organizations they will direct their request for collaboration, because not the health system only cannot address this problem by itself. No one can really solve this problem on their own. It's too vast, too broad to be done by one partner alone. That's why these determinants of health that we want to understand, we want to decipher which ones are the really important ones for cardiovascular population health. That's why we have to bring together these different partners from sectors such as the public and the private sectors, but also from different disciplines. Only then can we hope to have that substantial impact on the cardiovascular burden of a population like here in New York. So that's, again, my question to you. Do you want to do this with us? Launch this new ambitious initiative here in New York City today with us? Yes. Okay, thank you. So with that, I would like to welcome to the floor our super partners. And I would start with introducing, I have the pleasure to introduce you, Juan. Juan is the Chief Data Scientist of Microsoft. And Microsoft AI for Health will be a key partner in this whole endeavor to help us with the data science and all the work that will be needed to understand what comes out. So Juan, please.
Thank you. So 2 years ago, almost 3 years ago, we launched AI for Health. AI for Health is a $60 million program that Microsoft has that we realized very early that majority of the data scientists, majority of the experts in AI work either in the financial industry or in the tech industry. So we created this program to partner with organizations like Novartis Foundation, like NYU, to help from a data science to partner with them to create multidisciplinary teams where we bring the data science and the AI expertise on this. We were very lucky to partner on one of the first projects was with Novartis Foundation, with Anne. We work in leprosy with Novartis Foundation, and we really look forward to continue this partnership with this project. So I want to thank everybody for this, and I really look forward to having an impact on this. Thank you.
Thank you so much, Juan. And with this, I would like to introduce Julia Cartwright, the Senior Associate Dean of the NYU School of Global Public Health, to give us a welcoming address as well.
Good afternoon, and thank you, Dr. Arts. On behalf of our Dean, Dr. Deborah Verholten, and all of us at New York University School of Global Public Health, we thank you so much for joining us today for this timely discussion, the promise and perils of applying AI for health equity. We're especially grateful to our partners, the Novartis Foundation, and to Microsoft. It's now my privilege to be able to open the program with a new short video on this initiative, AI for Healthy Cities.
Thank you. And with this, it's my great pleasure to introduce you the Deputy Mayor, Ann Williams-Isom, who's a New York City Deputy Mayor for Health and Human Services. Please, Mrs. Deputy Mayor.
How's everybody doing? Oh, okay. I'm a Baptist, so you guys have to talk to me. I grew up Catholic, but I'm Baptist now, so we're going to talk to each other. It said keynote. I'm not quite going to give a keynote. I do think it's more words of encouragement and sort of thanks and gratefulness in this moment as we come together to do this very important work. So when I drove up here today, I was so glad that we're here at the New York Academy of Medicine for this important conversation, but also last night, or maybe it was 2 days ago, I have 3 children. I am a deputy mayor, and so that's very important, but my most important job is the mom of 3 adult children, 29, 26, and 20-year-old. And the 26-year-old said is now looking for a new apartment. And he said that he was looking for an apartment not too far from here on 111th and Park Avenue. And what he says, and he writes to his dad and I, and he says, I can see the projects, the housing projects where Daddy grew up. So my husband, Phil, grew up in East Harlem, this community here. It's one of the places in probably the country that has the highest concentration of housing projects. When my husband grew up there, I don't know, maybe a family of 4 made $17,000 a year. The crime rates were hard. Maybe 60% of the folks that lived there were not working and were on some types of benefits. So when I come full circle and I think about equity and I think about things and how neighborhood changes, we were like, Philip, are you sure you're in the right neighborhood? You want to buy an apartment across the street from where Daddy grew up in the projects? And it reminds us how when we go from generation to generation, how when we invest in communities, how when we do the things that we need to do for that generations can come back and make communities what they need to be. So before I get into my talk, I want to make sure that I say a couple of thank yous. I want to thank Tony Davis from the Federal Reserve Board, individuals from the New York City Health and Hospitals, yay, Health and Hospitals, colleagues from the health department and other health services providers, community-based providers, Vital Strategies, Health Finance Institute, Arthur Ashe Institute of Urban Health, international guests from the Federation Department of Foreign Affairs, the Center for Global Health and Development, people here from the private sector, Accenture, Microsoft, and many of the staff, faculty, and students from NYU, including the Dean of the Wagner School, Sherry Glide, and Ji Chan, also the NYU and the principal investigator of this project. Thank you all, and so many others that I don't have your names today. Thank you for this work. We are in such challenging times, and I say that it seems like all the time. We talk about unprecedented times and things that are happening. We are in this ever-changing phase of the pandemic with a new booster online giving us hope. We are managing the spread of MPV, monkeypox. We are monitoring developments on the polio front. I never thought as deputy mayor I would be talking about polio, but we are looking at that also. And we are pivoting and shifting, as the mayor often says, with the situations as they arise, and we are bringing the whole of government to bear what's necessary to protect New Yorkers. This past Friday and Saturday, we were right across the street at the City Museum of New York, where the mayor and all of the senior leaders in City Hall spent 2 days on a retreat. The question that we asked ourselves was, what will we be known for 8 years from now? When you go into the museum, you see all of the history of city government, and there's words up. Could be crisis, could be money, could be immigration, all of these things. And at the end of the day, what is it that we think this period of time we want to get done? It can't just be about crisis that we go to, but what is that forward-thinking issue? For many of us, because of our background and because of our backgrounds and the work that we've done, it is issues around equity and making sure that communities are connected to government and are part of the decisions that we make. So, and many of you have probably also heard that we are now managing the thousands of people that are coming to seek asylum here in New York City. This was something that started in May, and I think we are quite now up to almost 12,000 folks who have come to us from the shores of the border to seek asylum here in New York City. We're figuring out, what does that mean? That could be considered another public health crisis as we are connecting them to schools, to services, to our homeless shelter, and then to permanent. We know that so many people have come here across the years to seek refuge in New York City. So many of the organizations that are here tonight, I know, are playing a role in that situation, and so I also want to say thank you for that. When people ask me about all the different crises that we've had to face in the past 9 months, they say, you must be exhausted. You must be sorry that you took this job. And I have to tell you that when I look at the mayor and he says the same things, I think leadership matters more than ever. I wake up every morning grateful that I am in this seat. I wake up every morning that I feel ready to do this job. I wake up every morning with love in my heart and values in front of me. Because as smart as we think we are with all these new innovative ideas, I feel strongly, if you don't love the people that you serve, if you don't feel a sense of passion for this work, then I don't think you can make the difference or be the leaders that you need to be when times are as challenging as they are right now. And it is in this spirit of partnership that makes initiatives like the one that we're talking about today so important. It brings together corporate entities, academic centers, and our very own New York Health and Hospitals, among others, to tackle one of the most important issues facing us, health equity. And we talked a little bit about the numbers already, right? Heart disease is the second leading cause of premature death for New Yorkers, and has the second leading cause of been that second leading cause for 2 decades. Among racial groups, as we've already heard, heart disease is the leading cause of death among non-Hispanic Black New Yorkers. And we know that the rates of premature mortality are highest in neighborhoods impacted by decades of racist policies and disinvestment. Now, I feel like nowadays we just say sentences like this, and I'm not sure 10 years ago I could be in a room where we would say that and we would all just nod our heads. We've got to say that over and over again and know that there are things that we can do to change the structural racism that is built into these institutions. But let's do something different too. Let's start putting some faces on those figures. In 2019, New York City age-adjusted premature death rates were highest in Brownsville, followed by Mott Haven, followed by East Tremont, Marsena, and Central Harlem. Central Harlem, which is my community. It's the place where my mom, who's 91 years old and came here as an immigrant from Trinidad, has been living with my husband and I that I just talked about, who grew up not too far from here in East Harlem. We've been married for 30 years and where we raised our children. Why is it that in Central Harlem we have to have those rates of the way that we do? And why do we have to live that way? It's the place where I go to church and I sit with my pew sisters. You know, we're very protective about where you can sit in church, and they don't necessarily let other people sit there, but that's another story, who are all in their 80s and 60s, who have been affected by this pandemic. They're the survivors in some way, but have been isolated, who have to get access to good health care, who have to feel safe in going in the neighborhood. That's what I want you all to think about and center in yourself as we're talking about these issues today. I'll point out that for me, the point of this is that this work matters because there are people behind every statistic and every electronic health record. There is a mom in Marsenia, a dad in Tremont, a grandparent in Brownsville, for whom this matters so much. The second point that I want to make is really simple. And you are here tonight to leverage your technical research, analytical expertise, and tackle health equity. And the city is right here with you, but we have to do that together. The city's Board of Health has declared racism a public health crisis, and the Department of Health and Mental Hygiene is doing significant work to advance anti-racist policies, evaluate how it engages with communities across the city, and how it can build long-term strategies to tackle equity issues. We can't act like we're just going to do it next year. We're going to do it the next year before. We have to do these things now, and we have to have a sense of urgency as we come and we do this work. I know that Dr. Katz is working to advance policies to increase equity in H&H, as well as to as many other agencies across government. And can we just give a round of applause to Dr. Katz, please? I know. The only thing that I want to say is that I've spent most of my career in human services, right? I'm an attorney by training. I worked at the Administration for Children's Services. I had many years at the Harlem Children's Zone, where we really wanted to bring all of these issues, comprehensive services. So being here at this time, Mitch, it has been so important to have you as a friend and as a mentor so that he can tell me exactly what he wants me to do, and I have to listen to him. But I really want to say thank you for all that you've been doing for us. So, as you are in this evening tonight, it will be so easy to just dial it in, to be on your phones, to sit back, to just say, oh, I want to be here because I want to meet X, Y, and Z. But I'm asking you to do something different. I'm asking you to center yourself today and to have in your heart the face of someone who reminds you and who is important to you as you do this work. When I was at the Harlem Children's Zone, people would always say to me, Ann, what's the one thing that children need? And they would make me want to say, oh, it's the baby college, it's the prenatal care. Oh, no, it's early childhood. And I wondered to myself, when you love somebody, do you give them one thing? What I say to my 3 kids, oh my good, they're gonna get good prenatal care, but it doesn't matter what kind of after-school program they're in. Oh, I'm going to give them this one thing, but it doesn't matter, what college they go to. I just told you, Philip was on the phone with me last night talking about, Mommy, what apartment should I get? When you love somebody, you give them everything that they need for as long as they need it. Am I the only person that loves that way? Maybe. And so I'm asking you today to not just sit here and make this the normal, we're going to have a conference and this is going to be good, but to bring a sense of urgency and love and how you see the world to be different, because if you don't approach it and you all are the ones that believe in it, no one else will come along with us. So the people that are behind this statistic, they need to engage with the whole environment. They have families, loved ones, they need housing, access to healthy food, steady healthcare coverage, and so many other supportive things throughout the course of their lives. And they need it for as long as they need it, and they need it to be excellent. And that's the last thing that I want to say to you tonight, is that we are stronger together. We could do this work separately. We could be the doctors and the corporate folks and the folks from the academia. Or we could decide that we want to do something different, which is hard, working together. I know as I have 9 different agencies under me that I'm trying to pull in one direction, but I promise you that it will be different. The results can be different if you decide that you are going to go together. So thank you for putting your thoughtfulness behind this initiative in collaboration with each other and in a global context to support and learn from one another. I can't say enough about how important this work is and how important this type of collaboration is to improving the lives of New Yorkers and people around the world. Good luck. I hope you stay the course, and God bless you.
Thank you so much, Deputy Mayor. I think you deserve another round of applause because you gave us the best motivation we can imagine. Now we know why we are all here, and we will make it work, and we keep the people at the center, in our heart. This is our goal for today. Thank you for giving us that mission for tonight. With that, I would like to introduce our next speakers. Chang is Associate Professor at the Global School of Public Health in NYU, Professor of Public Health Policy and Management, and is also our Principal Investigator in this initiative. And Bill Weeks is the Director of Microsoft AI4Health. Please, the floor is yours.
That's a hard speech to follow up on. It's a privilege to be here, and Dr. Weeks and I will be presenting on some of the work that we've been doing so far in New York City. Sorry.
All right. Good evening, everyone. New York is a great town. It really is. I've been really enjoyed my last day here. So we're going to start, you talk a little bit about initially what's the motivation for this. And as Ann has already mentioned, that there are huge racial disparities in heart disease in New York City. More than double, while heart disease has improved over time, it's more than doubled when you compare non-Hispanic and Pacific Islanders to Black non-Hispanic patients. And there's particular health inequity in New York City, as was also mentioned. There's huge income inequities when you're comparing Brownsville, Brooklyn, which has a median income of $32,000, and the Upper East Side with a median income of $141,000. And also the reality that there's a huge difference in longevity when you compare longevity at birth. A family born to an Upper East Side family will live 11 years longer than a baby born to a family in Brownsville. We've often in healthcare focused on healthcare and quality to the exclusion of these other things. And the challenge is that healthcare and quality accounts for maybe 20 to 40% of the total outcomes of health in a population. So we're spending a lot of time on this and not as much on this. And so this is the CDC's framework for thinking about social determinants, all of which clearly impact the health of someone. And it makes a lot of sense, actually. Even if you're pretty sick, right, you may, and you go in and you're admitted a couple times, you're spending a fraction of your time interacting with the healthcare system, right? This is where you interact in your community and in your schools and in your neighborhoods. And jobs, and in America in particular, create the access to healthcare in the first place, right? Economic opportunity does. So these are important things to consider as we go forward and think about what our aim is, which is really to bring together data from a variety of different places, from healthcare, public health, and other health influencing sectors, as mentioned in the previous slide, to get new insights about factors that influence cardiovascular health in New York City and around the world eventually as we move forward. This is the kickoff. So this is our aim. I've been in healthcare, as you can tell from my hair, for quite some time. And for the first time in my history of studying this stuff, we have the data and we have the compute power to be able to actually do this and to model this out and to let deputy mayors and leadership know what might work when, for which populations, as they invest and get a return on that investment in health of the population. So now I'll turn it to G.
Thank you.
Oh, do you want this one or no?
Okay. Can I have the clicker? So I have the privilege of being able to present on behalf of our team here. So Dr. Pagán, Dr. Silver, Dr. Stacy Zhang, our faculty who are also involved in this project, as well as Zoe Lindenfeld, Elizabeth McNeil, Lugina Mustafa, Hee-Jung Sun, and Dina Zain. So this is work that we've worked on with the Novartis Foundation and Microsoft AI for Health for the last 6 months. And when this initiative was first brought to our table, we wanted to get an understanding of the lay of the land. Before diving into trying to answer research questions, we wanted to understand what is and isn't known already on this topic. And so with that in mind, we conducted a landscape analysis in 3 stages. First, we conducted a scoping review to understand what has already been written in the peer-reviewed literature. Specifically, we wanted to understand what is known about how data is being used to address cardiovascular health equity with an understanding of the impact of social determinants of health. Second, we know that there's a wealth of data, but we're not exactly sure about how that looks. And so we wanted to understand what sort of data are available out there about social determinants. How do we then categorize it so that we could use it to answer our research questions. And then finally, as Deputy Mayor as the Deputy Mayor mentioned, this is not an initiative that's just driven for academic research purposes. We understand the need to engage with the community. So we conducted stakeholder interviews with public health experts, insurers, health system leaders to understand how they currently use social determinants data and what solutions they think would be useful for them in their day-to-day lives. So very quickly, for our scoping review, we reviewed over 4,000 abstracts and extracted information from 51 studies that were included for the scoping review. And what we found was, even though there are a lot of studies that look at social determinants, many of them focus specifically on healthcare access and quality and neighborhood and built environment specifically. We also found that a lot of studies use electronic health records and neighborhood data to understand the impact of social determinants, but often they are not integrated. They're in separate studies. And risk scores were commonly used, but they almost exclusively relied on electronic health records. When looking at what data sources are out there, we looked at both the published and gray literature. We scoured through the websites of federal, state, and local government, and we found 57 distinct data sources related to social determinants. We categorized them by geographic level. So are they available by county, by zip code, by census tract, by block? And we also identified how frequently they're updated. And ultimately what we found was, as we expected, there is a wealth of data available on all social determinants in various geographic level. Similar to what we found in the scoping review, the two domains that are most widely covered in terms of data availability is healthcare quality and neighborhood and built environment. But all the other domains, there are a wealth of data out there, from those that are commonly known, such as the ARC, social determinants data, to even something like the number of tree counts or the number of licensed tobacco retailers in our city. For the stakeholder interviews, we interviewed 11 top leaders and executives and former executives from city and state health departments, insurance plans, community-based organizations, and hospitals and health systems. And we covered a wide range of topics around how social determinants data are currently being used, what data-driven tools would be useful to address health equity, and what challenges remain. And here's what we found. We found that the stakeholders we all spoke to prioritize social determinants data, and in fact, many of them use it in their day-to-day operations. Many use data collected directly from patients. Some also use data collected locally, such as through the New York City Community Health Service. However, what we found was that by and large, even though patient-reported data is useful, it can be very onerous to collect. Sometimes it's error-prone, and it's very time-consuming. We also found that the respondents noted that the area-level measures, neighborhood measures, are useful, but sometimes they're aggregated. They're so aggregated that it's hard to actually use that to drive decisions. So the takeaway from this was that from this landscaping exercise were 2 points. First, there's a wealth of data that exists on social determinants. We're not living in a city where it's a lack of data, but it's not clear exactly how we can connect them. Second, the currently available tools rely on patient level or neighborhood level data, but they're not often integrated. And so there's a need for a tool that's able to do both of these. So with that in mind, for our next step over the next 2 years, we want to address those gaps that we found. So first, in terms of the need for tools that utilize neighborhood level social determinants data at a granular level that could drive decisions, we aim to develop a multi-dimensional zip code level social risk score and a map for cardiovascular health across different specific domains in New York City. And then in terms of the value of combining clinical and non-clinical data, we are collaborating with New York City Health and Hospitals to validate and test this risk score and predict individual outcomes and needs using AI-driven models. And finally, speaking to the importance of partnering for impact, We are working with stakeholders in the community to test the use of this risk score and map to guide decisions. So that's the next stage of our initiative. And I do want to give a shout out to our great partner, New York City Health and Hospitals again. It's the largest municipal health system, and it was my first place that I worked after my PhD. And it's the largest safety net system with over 1 million patients served. And so if we want to have a partner to make impact with, this is the right partner to work with. And so we're very grateful for your partnership and collaboration.
So this is a picture by Gustav Klimt, who painted this for the University of Vienna's School of Medicine. And it was to be painted on the ceiling. And it shows a kind of a Greek goddess here of medicine. And then this is kind of the hope for the future. And this is the now, back in 1901, with people in pain and death, and having mental crises. Kind of the disenfranchised and the vulnerable are all here. And so the faculty of the University of Vienna unanimously rejected this, because in 1901 they knew that they were at the pinnacle of medicine, and they were offended a little by what they thought was pornography, but really that the thought that medicine could not conquer death and was not doing an adequate job treating these people who were vulnerable and needy. So unfortunately, this was bombed in a world war, so we can't see it anymore. But Klimt was quite ahead of his time. And in the last 12 decades, medicine's done a lot, right? I mean, we got anesthesia, which is kind of nice if you go in for an operation, and aseptic techniques, and we have antibiotics. These are all great things. But these people, we haven't been done so good with, right? And so that's kind of, for me, a very motivating thing about this whole initiative, is we're going to take on Klimt's challenge, 120 years later, to actually help these folks as best we can. And the way we're doing it, which is really exciting for me, is a novel thing, I think. What we're doing is combining some .orgs, right, with the .edu and with the .com, and we're all coming together, trying to influence maybe the .govs as well and be helpful to them in an effort to actually treat this vulnerable group of people in a kind of unique way, each bringing in what they can, everyone focused on the same outcome, all having a common ground that we're trying to reach. So this is really a tremendously exciting thing that we hope can be replicated across the world. And now back to you.
Thank you. That's it. And thank you. Next, I would like to introduce our moderator, Erin Billups. She's the national health reporter for Spectrum News, and also the host of Exploring Your Health. Thank you.
We are going to have a discussion. Hi, thank you so much for having me. This is a really important conversation. Data, when wielded responsibly, is a really powerful tool. And as the deputy mayor mentioned, it is important to have a person in mind. And the person I have in mind is one of my best friends. Her name is Lauren, and she lives in Brownsville. And I know you guys have seen Brownsville come up a lot. It's because it's a really dire situation in certain neighborhoods throughout the city, and the numbers aren't great in Brownsville. And Lauren and I talk about this a lot, that because she lives in Brownsville and because I live on the Upper East Side, we're both born and raised in the city, but we chose different neighborhoods to live in for different reasons. My life expectancy is 10 years, maybe even 11 years greater than Lauren's. And it's all because of the hospitals we have access to, the resources at the tip of our fingertips. Our life expectancies are very different. So Lauren's story is obviously more nuanced. She's a college-educated woman who knows how to navigate the healthcare system, but we've often lamented together about the difference of what's available in our respective neighborhoods. I'm more likely to be a healthy weight. 41% of Brownsville residents are obese versus 11% of Upper East Side residents. I actually live really close to here. I run past the Academy of Medicine often in the park. I feel safe there. I like going to the park and exercising because other people are motivated and happy to be exercising. And so that makes me want to get out there even when I don't want to wake up early in the morning. I can also easily grab a bite to eat at Sweet Green on 85th Street or Whole Foods at East 87th Street. There's no Sweet Green in Brownsville. There's no Whole Foods walking distance from Lauren's house. These issues are a part of the social determinants of health, which many of you are so familiar with, and we know why Brownsville residents have a harder time staying healthy. The data tells us. So that's why we're here. We're all going to dig into this a little bit more and see how we can leverage the data to better help all communities and bring equity, and so that Lauren and I can kiki together well into our 90s, okay? So I'm going to introduce our panelists, joined by, you guys heard a lot from Dr. Ann Arts. She is the head of the Novartis Foundation, joined by Dr. Mitchell Katz, the president and CEO of New York City Health and Hospitals. Juan Lavista Ferres is the vice president and chief data scientist and lab director of the Microsoft AI for Good lab, and Dr. José Pagán is chair and professor of the Department of Public Health Policy and Management at the NYU School of Global Health. So thank you all for joining. Mitch, let's start with you. I had the privilege of talking with you and some of your leadership during the pandemic, and even before, just covering the rollout of the electronic health record system for the whole city hospital system, just really connecting every single hospital. And it was fortuitous that all of that was done before the pandemic. So wondering if you could just kind of walk through how having access to data from every single hospital at your fingertips helped you respond to the pandemic during the darkest days, and lessons that you might have learned from that moving forward.
Well, thanks, Sarah. And I mean, for any of us who lived through New York City in March of 2020, you remember how horrible those days were. Those days when we feared we were going to run out of ventilators, we were going to run out of nurses and doctors to care for people who were critically ill. And key to us being able to manage the number of patients was being able to transfer them from those hospitals that were more crowded, especially Elmhurst and Queens, because very much to the topic of the inequities, those were the areas hardest hit. The immigrant communities surrounding Elmhurst was definitely point zero, ground zero, within a city of being ground zero. And so in order to be able to safely transport people from one hospital to another, we required very good data on how many patients were in each hospital, what our staffing was at each hospital, and then importantly, to have the medical information go where the patient was going in order for smooth transitions. Before we were able to go on an electronic health record, all 11 of my hospitals had their own system. It was basically a copy. They were all on the same system, but none of the systems talked to one another, and each had been sort of modified to fit the needs of that group. And so once we had the Epic system, which came live just about 2.5 months before the worst part of the pandemic, we were then able to transport patients. We knew who had room to transport, and when they came with their medical information, so their lab tests, their x-rays, so that nothing needed to be repeated. Also, it enabled many of us to work virtually because we could see the data from other hospitals, and therefore radiologists could read x-rays at the busier hospitals, even though they weren't there, because all of the data were in one place and as a system.
Yeah, so it is so important to have data talking, right? And can you talk a little bit paint a picture for us about the vision when you're harnessing data, digital technologies, AI. What are some of the ways that we could see these disparities narrowing?
Thank you for that question, Erin. In fact, maybe I go back a little bit where we come from. So why do we start this whole initiative, AI for Healthy Cities? Is that we've been working in the area of cardiovascular population health since quite a while, in the southern hemisphere, if I may say so. So we had large urban health initiatives in Sao Paulo, Brazil, in Dakar, in Senegal, in Ulaanbaatar, the capital city of Mongolia, and now also in Ho Chi Minh City in Vietnam. And what we learned there is that we can rapidly change the way cardiovascular disease is tackled in big urban populations, as long as you work together hand in hand with the local authorities. The local decision makers are in the driver's seat to decide what kind of interventions are going to be happening in their cities, and we guide them with the data so that they could have real-time data in their hands every time again and see where they had to readjust the interventions. And in 1 year of implementation in Sao Paulo, with that approach of cross-sectoral collaboration, we were able, in a well-functioning public health system, Sao Paulo is relatively well-functioning, to triple blood pressure control rates in 1 year time, and that translated in the reduction of 13% of strokes in a population of 16 million. So with that success, we said, okay, we want to now go one step further and also address these underlying determinants that are really much more important for your health than only the healthcare system. And there we ran into a challenge. If we want to do that in a city like Sao Paulo or Ulaanbaatar, we would have to start collecting that data 5 years, and we would be 5 years down the line. So that's why we come to data-rich cities. Which city in the world is better informed than New York City? You can know everything here, of the quality of your tap water, I hear, the quality of the air. You can know everything in New York City. So we want to use this wealth of data to combine them with the power of people like Juan and his teams, the brain power and the computational power of Microsoft AI for Health, to better to progress our understanding. I'm not saying we are going to get a silver bullet answer from this is the problem which we have to address. Maybe it's a combination of factors in the different domains. Maybe it's just a question of prioritization, but we will progress our understanding. And that's why we come to New York City. Other cities will be announced soon, but they are going to be in Europe, in Asia, as well, in data-rich environments. Because we believe if we don't do this now, we have no better opportunity than living in this era with the enormous amount of data available and the massive computational power available and the data science capabilities. So if we don't do it now, we are never going to progress that understanding.
Yeah, the time is right now, and
Yes.
this is a perfect segue to Juan. If you could talk about the logistics. You know, just making it all work is quite an undertaking. What are barriers, challenges you foresee in designing and implementing these sort of data-driven solutions?
I think the first barrier, for a very good reason, is to get usually access to the data. And there is a reason why. It's usually because, of course, if you're working with health data, you have to consider privacy. And we have been working in technologies, including, for example, differential privacy, that allow, because in reality, for all this work, you don't need the data at the individual level. You need the signal within the data. And technology like differential privacy helps us get access to the data in a way that provides guarantees that there's no privacy affected for those individuals as part of the data set. So yeah, usually the first step that we have is privacy. The second step that usually is a challenge is no matter how good your data collection system you have, there's always some bias in the data you collect. And it's really important to understand how the data was collected, to understand with the people that design the systems. Because if you don't understand the bias, you can end up in a wrong place. Let me give you an example. Right now, roughly 10% of you will be left-handed. Raise your hand if you're left-handed.
Only one?
No, we have more, we have more.
There's 3.
So there's a paper published in the early 90s, and Bill and I are working on this. That was like, it was published in the New England Journal of Medicine, and said the left-handed population was dying 9 years younger than the right-handed population. 9 years younger. That's as bad as smoking 120 cigarettes per day. And the only reason this happens is that for a long period of time, there was a kind of a discrimination against left-handed people, and parents would force their kids to be right-handed. Like, I know that because my grandfather was one of them. He was forced to be right-handed. And this generates this artificial increase, because eventually they stopped doing that. This generates an artificial increase in the population. But what's the problem from an AI perspective? If you don't know that, and you train a model using that data, the model will tell you that if you're a life insurance, you should charge more to the left-handed people because they will die younger. So it's really important to understand the bias in the data. And the third one, and you talk about this, is standards. No matter if you provide 10 people systems to collect data, all of those 10 people will come up with amazing solutions, and all of them will be different. We need to make sure that we optimize for the global. And that's why it's so important to invest in harmonizations of systems and creating those standards, basically, because that's usually the number one problem that we see is, and I think COVID showed us this, where like hospitals, when I'll be able to talk about hospitals, metrics wouldn't mean the same thing. So that's definitely a challenge. So.
Yeah. Jose, let's talk about academia's role, or what should it be, helping to translate all of this data into action.
Academia, right? Yeah. Critical role, especially at a place in New York City where we have, of course, a great school of public health that has been, because of the pandemic, growing incredibly fast. And one of the things that brings sort of like people together to a school of public health is the fact that, especially a graduate school, people go there because they want to solve problems that they see. And so what we have is academia in general will have a lot of talent, not only on the student side, but also on the faculty side in many different areas. So when you look at the data that Bill and G presented earlier, you basically saw this idea that social determinants of health, healthcare is, say, 20 to 40%. So everything else is the rest. And many of these students, many of these faculty study or come from these other sectors. So that level of enrichment is what you're going to get in an academic environment. And you need to integrate that into a project like this to make this happen. So we have the technical talent, and we have the sort of like know-how in many of these areas, but there are also gaps. We need the health system and data from the health system. We need a funder, and we need somebody that is looking also at the global aspects. And then we need folks like Microsoft that bring a level of technology and data integration that we don't have.
Yeah, so a starting point for collaboration.
Yeah. Definitely.
Mitch, let's talk a little bit about some of, dial in a little bit to more specific learnings that you've seen just on the ground in your hospitals. What needs to be tackled first in terms of underlying drivers of cardiovascular disease? And what are interventions that are needed now that maybe you have an inkling could be the answer?
Dr. Nicola Davis in her unit has done a lot of work in our system about improving blood pressure control and diabetes control. And I think really data has been at the heart of her success, because it's very easy for doctors to say, oh, well, it's very hard for me to have my patient take their medicines, or my patient doesn't like the medicines. My patients are different, they're harder to take care of. And what the data approach has done is to say, okay, well, here's where we are, right? You're never going to get to 100% control, but what you need to show is progress. And all of a sudden now there's an accountability measure which works both on the individual level and on the level of all of health and hospitals, which is we need to bring up the proportion of our patients who are controlled as diabetics, who same who are people who have a blood pressure in the right range. We now can look at it by doctor, we can look at it by clinic, we can look at it by categories of patients. We can assign now community health workers to go out to the homes when people have multiple visits and it's still not possible to control their disease. So I think data offers a lot in the way of accountability and of setting goals for improvement.
Yeah. When we're talking about equity, we have to point to the root of some of the issues, which is just existing sort of biases that exist. You mentioned this a bit, Juan. Wondering how can AI help reveal existing biases, and what safeguards are in place, you touched on this a little bit, Juan, to prevent historic health disparities from being baked into future algorithms. And this is something I'd love us all to chime in on. Juan, if you want to take a crack first.
Yeah, so we take that very seriously. One of the good things about, so let's start with the problem. Let's say you're training a machine, an AI model, and you have a bias whether certain ethnicities were not like there was no access to healthcare, or something was there, correct? Mm-hmm. If you build a model just based on that data, the model will just replicate that bias, and you will institutionalize that bias forever, basically. That would be really bad. On the good side, on the models, once you train a model, at least you can start asking models for example, one of the exercises that we typically do is you take a model, let's say you have gender, and you have a model that is, trying to calculate, for example, the probability of loan default. And you can change take the data and you can change the input data from gender and see if there's an effect. Mm-hmm. Because if there's an effect, there's something there that shouldn't be there. So you can interrogate the model. Once you have the model, you can interrogate the model. There are ways to try to help mitigate that bias, but recognizing that you need to start by recognizing that bias. There's also things that you shouldn't do, and that's why we invest so much on responsible AI. There's yes, you could do that, but you need to make sure that because of the data, you cannot guarantee that there's no bias, so we should not do that, basically. So, yeah.
Right. Anyone else want to chime in on that one?
I just want to give a promo to sort of anti-racist practices that one can do. We have an electronic health record. We use Epic, major billion-dollar industry. Has a very good application which is called MyChart. Lets people read their own records. I'm a huge believer in it. I see it all the time with my patients, the advantage. Well, it turns out it wasn't in their economic interest to ever write it in Mandarin. Well, we have in New York, a huge Mandarin population. So people can read MyChart in English, in Spanish. They can read it in Arabic because there was a major customer. They can read it in French. They cannot read it in Mandarin. Oh, okay. So we wrote it in Mandarin. We wrote it ourselves. And so now all of our Mandarin-speaking patients have the same access to read their records and see their labs. And so it seems to me that groups can look at specifically anti-racist policies and correct them.
Yeah. Nice.
Jose, maybe you can start us off on this next question, but more collaboration is needed across all health, non-health sectors. What are some other ways that we haven't touched on yet that you think additional collaboration is needed to make this effort successful?
I tend to think about the ingredients that you need to make something like this work. We've been at it more on the, it's not the pilot side, but it's sort of like building it for a year now, more than a year, probably thinking about it at least. Mm-hmm. So what's going to take it to the next level? And one is the issue of leadership. Having leaders that are interested and that are connected to the community, that are sort of like working together to make it happen. I think that's going to be a critical component to make it happen. Another one is having convening organizations that are willing to bring everyone together, having a safe space. And I think this, actually, the New York Academy of Medicine has played that role for many, many years on that. But But convening organizations also include places like NYU, it includes the Novartis Foundation, it includes all these partners that can make it happen. And the key is having a safe environment where all these ideas come in and then they can be sort of like mixed up and something good could happen. But it always has to start from a small group, and then it's just going to grow like you see here in the audience.
Yeah, I cannot agree more, José, that we have to work with very different partners, even non-traditional partners that we haven't worked with before. So I can give the example in Sao Paulo. We saw that in the health system itself, we didn't get access to young men, young adult men. They don't present in the health systems because it's always the women, the caregivers, who come with their parents or their kids. And you find them, you can diagnose them, but the young men we were missing. So then we went to the place where all young men go in Brazil. Tell me what it is.
Is it the barbershop?
Yes, that was also another example, but it was the football stadium. And we went to the football stadium and really offered screening for blood pressure screening there.
Good job.
And you find the young men who never present in the system. So you have to find other partners. The insights, the data insights will guide us to whom we go. But if I may make one point, for me, it's very important that we also speak to the people who live here. We have to listen to the people who live in these different communities with very different life expectancies or risks, because we want to understand how they feel themselves about this and understand how they see that their health could improve in their own opinion, because they know best. It's proven that if you ask someone, how healthy do you think you are, that it's very prognostic for the truth. So if we can listen to the communities and to the citizens who live here, will very, very much help us forward in better understanding the priorities to be researched on. And this is something we are still investigating to find that avenue as well.
Absolutely. We actually have some questions that were submitted from the audience a few days in advance, so let's shift to some of those. One question that I found interesting is, how do we encourage hospitals to share data? And this is something that I think we can kind of look to what happened during the pandemic and talk a little bit about it. While the electronic health record systems really increased communication and allowed for level loading within health and hospitals, it wasn't as, the connectivity was not as strong and the communication was not as strong between public and private hospitals. And so how do we encourage more sharing of data across hospitals, maybe even across academic institutions as well? And whoever wants to jump in on that, feel free.
It's a Microsoft question.
It is.
It's a data, I mean, the usual fears of patient confidentiality, as you expressed, really don't pertain, because there's no reason that you need to know somebody's name to benefit. You do need a linkage if you're trying to develop unique data. So you would need some neutral third party who could link and then eliminate the identifiers. But for a lot of your work, the confidential part isn't needed.
To add to that, I think, again, technology can definitely play a role helping, making sure we don't affect the privacy of the individuals, and that should be a priority. But I do think that another important, particularly in the case of academia, and I would love José's opinion here, is the fact that I don't think we have the right incentives to share data, unfortunately. Like, that is the fundamental problem, is there's not a lot of incentives for academics to share the data. And there has been this study that there's, like, usually some of these papers you will say, data available upon request, correct? That's one of the biggest lies in academia. There is this study where basically these groups start asking for the data available on request, and I think they ask like 1,000 papers, and 900 of those say, no, the data is not available.
Really?
Like, really not available. And again, it's part of the fact that there's not a lot of incentives. I do think that we need, as a society, we need to first recognize the value of data. Nobody can work. None of us either can publish or can do our work without the data. And I think it starts by recognizing the amount of people that are working to collect the data. And unfortunately, those are people that usually don't take the credit. The people that take the credit is the ones that present the data, build models with the data, publish papers with the data, but not the people that spend a lot of efforts building those data sets. So I do think that we need to change that as a society. I also think that in the case of academia, I think the journals can do a better job making sure that they, when they say someone is data available upon request, should be data, they should be there. But
So
let's go through José.
The pressure is there, and I think well, journals face that, and universities also face that. So I think that's changing a whole lot. But one thing that I'll say on this that you make me thinking about this in terms of like, I think if I need some data and I go to a health system or to anyone and I say I need the data, I have to know how to ask the data. I have to know I have to give them space for them to explain why they can give it to me, why they cannot give it to me. Maybe I need to get community organizations or people that can back me up to get that data. But I have to be also conscious that there may be things that I don't know on why they cannot provide that data. And that's sort of like the hard part. And it requires, we do it with students and faculty, and we have time to strategize how we're going to get this data. And then we go, so it's just a lot of back and forth. If you just go to someone and say, I need your data, and there's no context, it becomes hard to get that information. There's some examples that I've seen on that where you go talk to someone about data, and you quickly figure out they're not going to give me the raw data, but maybe they'll do the tables I need to explain to someone what's going on. So if we ask Dr. Katz, can you provide, for example, data on COVID cases or something? He probably has the data, and it's a matter of like, do I ask you how to provide it in a certain format, right?
Right.
And you may be able to do it or not.
Absolutely. Well, I think
It's all about building relationships.
and there is true time, right, to produce a data set. Yeah. There is, and maybe AI will come up with better ways, but it is true to the asker. Oh, you collect this data anyway. Just give it to us, right? Okay. Well, it doesn't exist in any form. Can it be extracted? Yes, but there's real effort.
Has to do it,
somebody has to do it, right? And I think often hospital systems are reluctant to say, okay, you universities, you just want data, so of course, we should just dedicate as many people as you need to crunch out your data so that you can write your papers. Well, no, we got other stuff to do. So.
It's an honest answer. Yeah. Okay. All right, we have another.
Completely hypothetical at this point.
Okay, I didn't know. Are we taking audience questions? Yes? All right.
I saw a hand.
But this is applying AI for health equity, so we can gather all the data, we can run it through the strong, most powerful computers, we'll have the best researchers, we'll get a slightly better sense of what the problem is. But how do you fix it? How do you do what the deputy mayor said, do the whole person intervention? There's not one successful example of that. So how are you working with the interventions to get to the health equity outcome?
I guess we need some tangible examples.
I mean,
we need to have the insights first, and then the goal is to really bring together the decision makers who can act upon it. In this case, if we have insights that can help health and hospitals, we go to Mitch. If it's insights that show that we need to talk to the urban planners or whom other non-traditional health players it could be, we will go to that kind of organization and see how we can partner to build a solution together. This is how we do this in all of the countries, but we didn't do it in these data-rich environments as we are now starting. There, I don't have examples, but we have a lot of examples of success stories of bringing together these kind of stakeholders and partners aligned behind the same goal and working towards the same goal. It does work very well because the proof is these cardiovascular population health initiatives, for example.
Was there something you wanted?
And I think within organizations, I've seen organizations that have made investments on data integration to make decision-making. One example that always comes to mind is, for example, how Health and Hospitals decides to locate a clinic, and they use data from the different neighborhoods to know, well, maybe we should rent a space here to put a facility because the members of the community have a hard time getting there and so on. I mean, and they do it at the sort of like, they don't have an infinite amount of staff to figure that out, but they have enough data to make those decisions.
Yeah. Another question we had is kind of going back to privacy concerns. There's a growing push to optimize AI in order to better recognize people of color, but there are growing concerns about privacy. How do you make AI technology equitable with a public that may have mistrust of the institutions that will likely have access to this technology, like the government, health tech organizations?
So that's a great question. I do think that it first starts by transparency, correct? In the sense that you need to build your models, you need to make sure that those models are open source, are published in papers. And again, this is not related to this specific project, but in general, that's a practice that we have. Is like, you need to make sure that people understand the models and people can question the models. And again, from an ethical point of view, you went through the reviews on making sure you're not generating any bias on that. And like that's meaning that is a great question because it's a problem that we face, particularly in the case of bias in the data. But we want to help, like we want to work on the process to make sure that some of those you at least try to mitigate. So.
Yeah. Is this any of you want to chime in on that? Maybe even the workforce around this movement of using AI to optimize health outcomes should have a diverse representation of the people being served. That's one of the concerns out there, and how do you hope to, galvanize a good workforce behind these sort of efforts?
Yeah, I fully agree. Teams need to be diverse,
yes,
and that starts with that. And we have a lot of examples on how non-diverse teams end up with the wrong results. So, yeah.
So, yeah, one example on that that I've seen, for example, going back to Health and Hospitals. I wonder why, but it's connected to how the health system looks at social and racial equity as central to every activity, and the way that gets operationalized is that every activity that you do, you sort of like are consciously thinking about it. So, for example, if you are developing a clinical algorithm, you take that into account. If you have case reviews, you ask that question. If you're hiding, you ask questions like that. So the same approach applies to if you're developing an algorithm or a AI system that integrates data. Do you have the right team to get the work right? You ask the question. You force the question in the process. Are there areas in which this may fall apart and some groups may be harmed or may not benefit from it?
Yeah.
And that's it. Bring it, add it as a question.
Yeah, it goes back to what Ann said about listening, right? We have another question. Oh, we have a mic.
There's a mic. I'm sorry. Hi, Joe Buford from NYU. Congratulations on this. I think this is really exciting, and I want to bring us back specifically to a question regarding this project because Professor Chang mentioned the issue of developing a risk score from big data and then actually picking a geographic area, community in which one could begin to look at a zip code level or a neighborhood level beyond the medical record, and what I think H&H probably does a better job than many places, asking questions of patients about, are they employed, do they have food anxiety, et cetera. So those show up in the electronic health record, but would not be the same as talking to an ag and markets agency or a parks department or others about the specificity. So I would like you to talk a little bit about the geographic area question and kind of bringing it together with the community engagement that Ann mentioned earlier.
Maybe Dr. Zeng needs to answer that question. Or Dr. Weeks, maybe.
Yeah, you can feel free to.
Yeah.
No, it's great.
It's very important.
Thank you for that question. And okay, so I think that I agree with what you're saying, and you raised a really good point. I think from the get-go, we were trying to understand how do we actually make an impact, and so that's why we're taking it piece by piece, right? So I'm a health equity researcher, and a big model in health equity research is developed by Kilburn and colleagues, and the first is to sort of describe whether there is a problem, right? And so I think with the maps, that's what we're first trying to do, right? And then second, you have to understand what's going on, what is actually driving it, and that's sort of linking it to the health and hospital data. And then once you have that, then you can go into the intervention part. And to be honest, we don't know, that's still a question. And we're hoping that the stages that we're going through will help us understand, you know, what is the intervention that would work in the community? We don't know yet, right? And so, but I agree with you. I think that that is the end goal, but we're taking it piece by piece at a time.
And to add to that, again, the model, the data will not give us a causal relationship, correct? You can only find things that have predictive power, and you can try to control for as many things as you can, but at the end of the day, you will need, it's very good to generate hypotheses and then work from those hypotheses. It will not give you the causal results, basically. So,
I'll add that we do have some ideas of communities that we could work with and so on, and have had conversations about that. At the same time, the purpose of a forum like this is for you to tell us too, like, are you interested in this, and is this something that you want to have a conversation? Because of course, that would go a lot smoother than if I just go somewhere and say, I don't even know whether you need something. I don't want to do that. But we've talked about that in terms of like looking at the data, the maps that were shown earlier, sort of like who are the community organizations in that place that we know or that we can have conversations with. And all those interviews that Ji Chan mentioned earlier and Bill, they were very eye-opening because you know, we went in with sort of like this project, and we ended up with a lot more information than we expected, or needs and so on.
So I think there's still more to come, but thank you all for joining us for this conversation. Thank you to our panelists.
Thank you.
Thank
to
you.
Thank you. Thank you, Kim.
Thank you. I will be.
With that,
Maybe we can, or you can stay, or
we
you
can go
can come up.
we will get off the stage.
I would just like to take the opportunity to end our very nice event here. And first of all, thank you everyone for participating. But what I heard here today is that to start with, from the deputy mayor, how important is it? And it was for me really a wake-up call to hear it from the deputy mayor, how it is centered around the people who need it. And that is the goal of this initiative, exactly what we had aimed for. So we need to work together. All these different sectors, all the different disciplines, we need to bring it together and make sure we can translate it into action. I very much appreciated your question, sir, because that's the overall goal. Of course, the research results will be interesting, but the action will make the difference. So thank you again, and let me end this session here by sending a very big thank you to the team of G and José, who have been preparing all of this work, who have been preparing this event. It has been fantastic. Thank you very much, Julia, for your help with preparation of the event. Thank you to Joe Beaufort, who was the person who first started to talk about the need to do this, because it's not been done. Everybody talks about social determinants of health, and then no one has really been joining or combining these different data sets to find the answers, or at least the first answers to the major questions we are trying to respond to. Then I want to thank Juan and Bill, of course, for the fantastic partnership with Microsoft AI for Health. and the whole Novartis Foundation team who has been preparing this with Sarah in the lead, Elizabeth and Caroline here with us today. Thank you, everyone from the NYU team, whomever I forgot. And let us now enjoy a little catch-up between us all here with an apéro in the back of the room. Welcome to have a drink and a little bite, I think. Thank you, everyone.